Morning. My name is Sanjeev Anand. I'm a knee surgeon at the Trust, and we're going to talk about assessment of acutely injured knee. Uh, this topic is best taught face to face, but we'll try our best, and hopefully we'll be able to learn how to manage these common injuries. I don't know if any one of you have ever had a knee injury, but they can be difficult to assess. And even if you not an orthopedic surgeon, these are commonly seen injuries and are one of the common cause of presentation to GP practices or to A&E. And well, if you look at the pictures and tell me what's going on over there, what you can see is there is a complete disconnect between femur and tibia on both these views. And that would usually happen when all the ligaments connecting the two bones have torn. And that's called a knee dislocation. And fortunately, this is a rare instance, and you won't unlikely to see in your practice, but that just shows the extreme spectrum severity of these injuries. More likely you'll see people like this, the young people injured their knee on sporting fields, and increasingly sedentary people, overweight, who injure their knee. And these are actually even more difficult group because they often injure the knee, they get ignored, and the soft tissues mask the signs. And but because of their weight, there's a lot of momentum goes through the knee joint, and the ligaments are not that good. So they actually can have a significant injury, significant damage even from trivial injuries. So think about these patients as well and don't ignore them. So what we're hoping from today's talk is that you will understand which acute knee injuries would benefit from being seen urgently, identify patients needing urgent treatment and urgent investigations like MRI scan. So like anything in medicine, we start from the history. The velocity of injury is really important, and a high velocity injury obviously will cause more damage compared to a low velocity. So if this footballer, if he starts twisting his knee, and if you see the image below there, if the velocity, if the forces stop, he may just end up having an injury to his medial collateral. But if the same forces and the velocity carries on, the force will go through the knee joint and would tear ACL or central ligament. And if the forces carry on, it will tear lateral ligament and leading to situation like a knee dislocation, which we alluded to earlier. But if it's a low velocity, this could end up being just a simple MCL injury without any serious consequences. Whether they get his contact for the time of injury or non-contact helps and gives an idea of the direction of forces going through. You would have heard of ACL injury, and can you think what more likely would it be, a contact injury or non-contact injury? What would you think? Majority of ACL injuries are actually non-contact injuries. Usually somebody is trying to kind of suddenly change direction while the foot is planted on the ground, and then whole upper body twists in another direction. So more often than not, it's non-contact injury is ACL injury. But if there's a contact, the direction and location of forces is useful to know. So this person had what's called hyperextension injury by somebody landing on top of him, and those hyperextension forces can tear ACL in the middle. But if this player, as he lands on his leg with another player on top of him, the tibia gets pushed backwards, and that tears PCL, which is the ligament behind the posterior cruciate ligament, which stops tibia from subluxing backwards. And the common scenario for such injuries is what we call dashboard injuries. The driver hits a vehicle, hits a stationary object, and the forces get transmitted to the front of tibia, and tibia goes backward, leading to PCL injury. And often these are missed because of the other distracting injuries to other body parts, and they get missed. But history can be deceptive, and this video demonstrates that a similar twisting injury can cause patella to dislocate out of joint or tear ACL. So it's something which your subsequent examination helps to clarify. Usually a twist with leg straight causes patella to dislocate a twisting injury with the knee bent will stretch and tear your ACL. So again, history can be confusing. So if you see this picture, this is a left knee, and sometimes patient would come and say, my patella dislocates medially. Can you tell in this picture which side is patella? Is it this way or is it this side? So that's the lateral side. So actually, the patella is there, so it's a lateral dislocation. But what patients often see is a bump, which is a distal femur on the medial side, and they think the patella is dislocating medially. So it's what patient gives history has to be tempered with your knowledge of what is actually happening inside the knee joint. Patella never dislocates medially unless somebody has had previous surgery, because the quadriceps pull with the direction of pull pulls patella laterally always. So the other important point of the history, and it's the most important point if you want to take from this talk, is history of swelling, as you can see in this left knee. So what do you think really causes swelling after injury? So swelling after injury is from blood in the joint. So if you injure your knee and structures tear or damage and you get blood, which is called hemarthrosis. So think about the structures which can be damaged and which may cause hemarthrosis after injury. The commonest one is ACL and sometimes PCL, but the ACL is the commonest injury which causes hemarthrosis. Okay. It's an intra-articular structure, it's very vascular, and as it gets damaged, you get a lot of bleeding in the joint. The other tear is meniscus tear, is other common cause of bleeding in the joint. The swelling between the two differs, the ACL being very vascular, after injury, the knee swells up immediately. Unlike meniscus tear, which is less vascular and the swelling happens slowly, and most people would say that the knee swelled up overnight, they wake up next morning with a swollen knee, unlike ACL where it's an immediate swelling. Patella dislocation, if patella goes out and as it goes back in, the two surfaces collide against each other and they can cause damage to the joint surfaces, and that's also another common reason for getting swelling and bleeding in the joint. Of course, fractures can cause swelling and as bones bleed, but this should be usually visible on X-rays as a presentation on A&B. So onset of swelling is important. Like early immediate swelling is either from a fracture, visible in X-rays, could be from patellar dislocation, but more often from ACL injury, while meniscus tears cause slow onset of swelling. Often people with ACL injury may feel that they get a pop from the tear or the damage which happened, and sometimes even meniscus tears can give a similar feeling of pop. So examining these patients and they come to you can often be difficult. They've got painful swollen knee, they're not very cooperative. So what really this exam for the second part of the talk is for you to assess common acute injuries which would to identify which can be treated, which need to be treated acutely and soon urgently. So that's what our next part of the talk is about. So when you examine, you need to think what's happening inside the knee, what's under the skin, and you need to understand what's the anatomy. And so you thinking what lateral collateral sitting outside, medial collateral sitting inside the knee, but they are part of the capsular envelope, unlike cruciate ligaments which are inside the joint. So these are the major structures besides of this, the meniscus and the joint surface which can be damaged. So think of these structures. So when you try to examine, assess and palpate different parts and look for clues, think of what's hiding under the skin and where those structures are located. So what we want to find out really is conditions require urgent intervention. A ligament injury, especially something with a severe ligament injury where you have actually knee dislocation. A pure cruciate ligament, anterior and posterior cruciate, don't always need treating acutely unless they're combined with collateral ligament injury, when it goes towards the territory of multi-ligament injury or a knee dislocation. So it's very important that you identify collateral ligament injury in presence of anterior or posterior cruciate ligament injury. Other thing you want to find out about is patellar dislocation, especially as I mentioned, if patella goes out and as it comes back in, the two surfaces collide and they may sometimes cause a shear fracture and will lead to detached loose fragment. We want to know about if there's a meniscus tear, and the kind of tear we worry about is a tear what we call a bucket handle tear, and we're going to talk a bit more about that. And we also want to know if somebody has torn their extensor mechanism, which is quadriceps tendon, patellar tendon, and they can't lift their leg up because of that. And of course, fractures. But fractures are often picked up on X-rays in A&E. They're the soft tissues which get missed. So when you look at patient, we go through the usual look, feel, move sequence, and you get lots of clue on looking. So the picture on the top, you see it's a swollen knee. So you get swelling because of the bleeding inside the knee, okay? And then you look for bruising, okay? So bruising is when the blood is actually outside. Swelling is when blood is retained inside the capsule. So this is the attachment of the capsule around the knee. So if you have an injury to structure inside like ACL and PCL, the blood will stay within this capsule range and you'll get a swollen knee. But if you have damage to the peripheral structures, the collaterals, the bleeding will be more visible outside the skin and that will lead to bruising on the skin. And if bruising is medial, you can think it's a medial collateral injury, but if it's lateral collateral injury. So again, this picture shows that the extent of the capsule, which is green, it goes quite high up above patella. And if you have a lot of bleeding, the swelling will go high up above patella and it will be very visible. So in this picture, the swelling shows that it's intra-articular injury, and this one bruising shows more towards the side, lateral side, and I'm thinking more lateral injury. So, but if this injury carries on and the capsule bursts because of the forces carry on the knee, the blood from inside knee will come out the side where the capsule is torn, and you will see much more bruising in these patients. So that will suggest a much more severe injury. So started with the intra-articular injury, then the capsule tore, and you got more bruising outside. So bruising could be simple, just capsular injury or collateral injury, not much. But if it's massive, you need to think it's the blood from inside has bursted down and now it's outside. The next thing you want to ask patient to do is if they can lift the leg up straight. If they lift the legs up straight, I know that extensor mechanism starting from quadriceps, patella, patellar tendon is intact. And of course, the hip and everything else is intact. So just a simple task of asking them to lift the leg up from the bed tells me a lot about the whole extensor mechanism. Next thing is I want to lift their leg up. And if I lift the leg up, if they get, this is an extreme example, if they get hyperextension like that, you compare from the other side, that suggests that there's the injury structures at the back of the knee, namely posterior cruciate ligament and posterior capsulis torn. And you see other telltale signs like bruising at the back of the knee. And the other thing is the lateral collateral is relatively posteriorly located. And then if that's torn as well, knee slumps backward and kind of rotates externally as well. So the patient which we've just seen over there, and that presented with this obese patient, and that presented with this X-ray, looks very innocuous. Can you see what's going on in this X-ray? You might have spotted that there is a fracture at the top of fibula. So you need to think, really, this gets missed as an innocuous fracture, but you need to think what's attached to this piece of bone. It's a lateral collateral ligament and biceps, which is attached to proximal fibula. And this fracture is a avulsion fracture that suggests that LCL and biceps have pulled off from top of the fibula, which are important stabilizing structures of the outside of the knee. So if you identify that with the examination and on this X-ray, you can fix this back, get bone-to-bone healing, and good early recovery. So think and look for these structures and on images. And patellar fractures, patellofemoral joints, the key thing we're looking for is episode of patellar dislocation. And as this picture shows, it's the patellar dislocates. As it dislocates, it tears this ligament called medial patellofemoral ligament. But as it goes back, the two surfaces, medial patella and lateral femur collide, which is visible on this MR scan by bruising on medial patella. The whiteness is bruising on medial patella and lateral femur. So this picture shows what happened at the time of injury. Patella went out, and as it went back, this bit hit over there. So what you're trying to see in these patients is if they got tenderness over there, along medial patella, femoral ligament, and as you try to push patella out, as is shown over there, patients don't like it because they're worried that patella may dislocate. So if you can do that, you think if this patient may have a patellar dislocation. The next thing is you want to figure out whether they torn their anterior cruciate ligament, and you would have been told about this anterior draw test. It can be difficult to perform anterior draw tests in somebody who's got very painful knee. Their muscles go, hamstring go into spasm, which will tip them backward. They don't like knee bending backward. Another thing is, as you try to do it in this flexion, the posterior horn of medial meniscus acts like a doorstop and stops tibia from going forward. So a more sensitive test is the Lachman test, which is done with the knee in slight flexion. And all you're trying to do is pull tibia forward, and you're looking for a excessive movement and a soft end point. So it's a soft end point. If ACL is intact, you get what we call a little bit of movement, and then the ACL stops tibia from translating forward, and it's a firm end point. So that's called Lachman test, and it's more sensitive than draw test, which you used to do it. For the next thing, you want to see if there's a PCL is intact, and all you try to do is get them to bend their knee in whatever degree of flexion they can achieve, and look from the side, both knees. So normally a tibia, so the left knee over here, tibia is normal position. It's proud of femur. It's about 5 millimeter or so, about centimeter proud. And you can put your finger or a pen over there to see if it's proud. But if the tibia is sagging backward, your finger or pen will touch the front of distal end of femur. And that suggests the PCL is not good, it's stretched and tibia is subluxing backward. And you can do it in whatever degree of flexion you can achieve with the foot resting on the bed or couch. The next thing you want to assess is what's called collateral laxity, and that's done by providing varus and valgus stress, and that tests for lateral and medial collateral respectively. And that's best done in 30 degrees flexion and in extension. Why do you think we have to test in both positions? If you see this picture on the right, that if your knee is in slight flexion, the posterior capsule becomes loose. And when you give varus or valgus stress, you're testing purely for collateral ligaments. So you will get an increased opening if it's pure collateral injury. But if you test in extension, the posterior capsule becomes tight. And now if you give a varus valgus stress and the joint still opens, that means both medial or lateral collateral and capsule, both of them have torn. Besides collateral, the posterior capsule has torn as well. That suggests a more severe injury, which requires more urgent intervention. In extension, a pure collateral ligament injury would not open the joint because the posterior capsule would stop the joint from opening. So if the joint opens in extension, that's much more severe injury. I hope this picture does clearly illustrate that. You must be used to seeing arthritic joint. This lecture is not about arthritic joints, but arthritic joints may give this apparent impression of laxity, but that's a pseudo-laxity. That's because if you have a collapsed arthritic joint, and as you give valgus stress, joint gets to its normal opening, which is different from increased opening in a normal joint from collateral injury. The last bit you want to see is the lateral structure, and one easy way to do is get patients to get their knee in this figure of 4 position, and then you try to feel a lateral collateral structure on outside. And I would suggest you try to do it on your own knees. If you're sitting on a chair, get your leg in this position and try to feel for lateral collateral ligament. If you can feel, you would be able to feel a tight band on the outer side of your knee. And I suggest you go in perpendicular to this band. You will feel a cord-like structure, usually best felt around the joint area between femur and tibia. try to feel it. It's really, you'll be able to feel it, and it does give you that kind of a light bulb moment when you can feel that. The other intra-articular structure we want to look for is called meniscus tear. So meniscus are cushioning cartilage, but the key bit which we want to, apologies for my hand-drawn picture, is what's called a bucket handle tear. So meniscus is like a C-shaped structure. If you got a tear to the periphery, the meniscus can then flip uh, on its what's called two handles really. So like a bucket handle, the meniscus will flip in while connected to the two push horns or the front and back bit. And then it gets lodged in the middle of the joint and stops leg from going fully straight. So that's more like a relative emergency really. You want to push the meniscus back and stitch it back. So, but this loss of extension can happen occasionally if there is a tear to the front, and that may be because of the pain and patient and where it doesn't want to push the knee straight because it hurts when there's touch the front torn meniscus, or if from an ACL injury, a patient has a torn stump and that stops from a knee from going fully straight. And the other thing which happens in the meniscus tear, they get tenderness along the joint line, and that's something you need to learn to feel. And with this, that corroborates if the tear, which will be the meniscus. Unlike collateral, which are of attachment, which is away from the joint, meniscus tenderness is at the joint level. Often the examination is difficult, and if it is difficult, don't hesitate to repeat examination in a few days again. After examination, next thing is you're looking for x-rays. I don't know if you can appreciate anything wrong in these x-rays. Can you see this small flake of bone? This flake of bone is called a Seagon sign, and that's because with the injury in the knee, the lateral capsule, which is attached to tibia, gets torn. And that's this sign. If you see this picture, it's pathognomic of ACL injury. So that ACL injury, when the force is carrying on, some ACL injury will tear the lateral capsule. So a flake of bone on the outer side of knee is very pathognomic of ACL injury, and it's called Seagon sign. Do you spot anything in these x-rays? You might have found this small flake of bone. So this flake of bone is from patellar dislocation, and it's a visible bone from an osteochondral fragment. If you only see the osteo bit of an osteochondral fragment, if the bone bit is very small, you may not even see that, and it may be a large cartilage fragment. And this happens from the patellar dislocation, as I explained earlier. Patellar dislocates out, it tears middle ligament, and as it goes back in, the two surfaces collide, and they collide. They may take a piece of cartilage out from either from lateral femur or medial patellar. And if you can identify that, that's really important. As this MRI shows, this is normal joint, and this side is abnormal joint. And this almost a quarter of, this is a young boy, a quarter of the joint surface has been missing because when the patellar hit there, it took a piece of cartilage out. And if you don't identify and fix it early, they have that significant impact on the joint's health. This is just an intraoperative picture. It's that white red is the raw area, while this white is a loose piece of cartilage lying in. And if you identify that, this can be fixed and restore the articular cartilage. So from there, we can get back to this state as a normal joint surface restored. So that's what we're hoping to achieve by trying to identify these injuries. You do MR scan if you're concerned these patients, if you're worried, and you may pick things like ACL injury based on your initial suspicion. And that's the ACL going there, which is not intact. It should go all the way up. On the further slices in MR scan, you often see a picture. Again, the white is bruising, and the T2 image, you're seeing bruising in the front of femur and back of the tibia, and there's a bit of divot there. So what's happened is, this is a picture of what happened at the time. So femur went backward. As it went backward, it stretched and tore ACL. This bit of femur collided against back of the tibia, and the patient's knee relocated. And what you see with lateral scan is this sort of bruising pattern. And if you see that, you can be 100% sure that this patient would have had an ACL injury. So in summary, what we're hoping to find out from examination in acute injured knee is whether the patient has torn their ACL, PCL, have they done a collateral injury, because we want to find out if it's a multi-ligament injury which requires urgent intervention, have they done a patellar dislocation, and there's a fracture from that, and if they have a meniscal tear. So what I want you to do from your examination is look at just these few things. So you want to find out if they have any swelling or hemarthrosis, you want to look at the extensor mechanism and range of movement, and I want you to assess the collaterals. Because if you find there's swelling after injury, that could be either of these. There's not many other reasons really. It's ACL injury, meniscus tear, patellar dislocation, or chondral fracture, which can be picked on X-rays. If they can lift their leg up, that means they haven't torn their patellar tendon or quads tendon. And if there's a block to extension, that means they may have a bucket handle tear. If the collaterals are intact, that means they haven't done their multi-ligament injury. The knee has not dislocated. It's useful to recognize ACL and PCL injury, but they can often be dealt electively unless they have an associated collateral injury when they need to be dealt acutely, because that's a knee dislocation. If in doubt, sometimes you need to examine this patient under anesthesia. So this patient had a really big patient. She had a compartment syndrome after a knee dislocation, had an external fixator and fasciotomy done. And we couldn't get good MR scan because of external fixator, and we had to get the patient under anesthesia to examine the knee and assess for stability and the ligament injury pattern before we start doing any reconstructive surgery. You can see this excessive degree of abnormal movement which is there, which can be really difficult to assess sometime in a weak patient. There's a guide on YouTube, which if you wish, you can have a look on the examination. So I'm sorry, this is a webinar online, but if you have any questions, I think there's plan for some face-to-face questions. I might have some questions for you, just to give you some scenarios and from what we commonly see. So the first scenario is a young football player who suddenly turned while going for a ball and felt a pop and collapsed. He noticed immediate large knee swelling and was stretchered off the field. So what do you think is going on? This patient, this history is very suggestive of ACL injury, and that's what I'm thinking of. And we should confirm your examination, but I wouldn't want you to assess for collaterals. And if collaterals are okay, it's unlikely to be multi-ligament injury. And pure ACL injury, we can start with physiotherapy in first instance, and then we look for instability symptoms. And if they have symptomatic instability, and what we're looking for is instability when they pivot, turn on that leg, and the knee would collapse or give way, and that would be a candidate for surgery. And there's a BOA document on that, which you can access if you want to. Okay, so slightly similar-ish situation. Young chap twisted his knee while pushing heavy load. But here, this guy woke up next morning and noticed swelling in the knee. So what do you think is going on? And then when you assess, his knee would not go straight. So what would you do? So this scenario is more suggestive of a meniscus tear, because meniscus is less vascular, and a peripheral tear would cause bleeding, but it happens over slowly. There are different sorts of meniscus tear, but the urgent tear is something where the block to extension is in a bucket handle tear. So if you think there's a block of extension following such injury with a meniscus tear, you need to refer this patient for an urgent surgical treatment, because this meniscus needs to be reduced and repaired to allow normal knee movement. So, but this chap is 50-year-old, and he kind of had a more trivial injury and similar sort of presentation with the swelling. What do you think? And what would you do? Look, not all meniscus tears are same. As we get older, it's almost common to get meniscus tears. Meniscus get more squishy, and a small twist and turn can tear them. And if you scan, say, 100 people, more than 50-year-old, about 25% will have a meniscus tear on the scan. And the older you are, the incidence of normal meniscus tears goes up. So the tear on the young footballer is different from a middle-aged weekend warrior. So this older person with what we get what's called a degenerative meniscus tear, they usually have association with some arthritis in the joint, and more often you would want to give them a chance for knee to get better, and often they would settle with physiotherapy and some rest. And surgery is only considered if symptoms do not improve and they have persistent mechanical symptoms like locking from a flap of meniscus tear. A last scenario, and this is a common scenario, a young girl twisted her knee, felt her knee move out of place, and knee swelled up. What do you think is going on? This patient had a patellar dislocation, and we alluded about the mechanism, but it could be ACL injury. You want to ensure you don't miss that because there was similar twisting injury and ACL injury. In the patellar dislocation, what we're looking for is does the patient have a large bleeding, large swelling? If they have a large bleeding or swelling after such injury, I'm worried that this patient would have a high likelihood of osteochondral fracture. I would arrange an urgent MR scan to look for that because we got only a short window of about 2 to 3 weeks before we fix that fragment. Otherwise, it gets difficult to fix them. If there's a loose fragment, that patient needs urgent surgery. But if there's no loose fragment, we need physiotherapy to get the knee mobile. But you need to warn patient and family that there is a high risk of recurrent dislocation because this structure remains weak, the MPFL. And if the patient dislocates again, you may want to consider reconstructing that ligament to prevent any further patellar instability, but that can be done on an elective basis. So that's kind of an overview of acute knee injury. I think there is an option for you to kind of log into a team meeting to ask questions. Hope the session was useful, and I look forward to talking to you and discuss this further.